I'm presenting SB 1254, which would require a pharmacist at a hospital to confirm an accurate medication profile for each high-risk patient upon admission of the patient. I would like to thank the chair and his committee for working with us on SB 1254, and I'm very happy to be taking the committee amendments today. It's startling that up to 70% of patients have errors on their medication list upon admission to a hospital, and up to 59% of those errors have the potential to cause moderate to severe harm. There's currently a lack of oversight for ensuring that such medical lists are accurate upon hospital admissions. This lack of defined responsibility results in errors in the lists and errors in medication orders when patients are in the hospital and, in fact, when they're discharged. Not only does this lead to significant harm to the patient, but studies have shown that this problem also costs billions of dollars due to medication-related readmissions and adverse drug events. This bill will better ensure the accuracy of what patient medication profiles are at admission, thereby potentially stopping any errors, which will enhance patient safety and reduce physician and hospital liability, including after the patient's discharge. I would like to introduce Dr. Rita Shane, Chief Pharmacy Officer for Cedars-Sinai Hospital in Los Angeles and Professor of Medicine at the University of California, San Francisco. And thank you. I encourage your aye vote.
Great. Thank you very
Dr.
much,
Shane.
Senator. So if we could just pause for a moment so we can establish a quorum. Committee Secretary, please call the roll.
Lowe.
Here.
Bro. Arambula. Baker. Bloom. Chen. Chu. Cunningham. Eggman. Fong. Gibson. Grayson. Holden. Irwin. McCarty. Medina. Mullen. Oberloti. Ting.
Great. Now we have established a quorum, and please, we'll have to allow up to 2 minutes. Please present whenever you're ready.
Thank you so much. Thank you to the Honorable Senator Stone and to the Assembly for allowing me to discuss what I believe is a really critical patient safety issue in the state of California. So I'm going to start with a personal perspective. 20 years ago, actually last month, my father was diagnosed with lung cancer and had surgery and a series of needs for medications, and I was kind of startled by some of the findings then. He was discontinued on a medication that was important to prevent swelling of his brain. When he was discharged to another hospital, the hospital did not know that he was on the medication, which created all sorts of untoward side effects. He also had other comorbidities that ended up not being treated effectively just because of lapses in getting an accurate medication history. I vowed then that this would be my career goal, to make something happen to ensure the accuracy of medication lists. Many years later, more recently, my elderly aunt had multiple conditions and was frequently hospitalized. During one hospitalization, her medication for her breast cancer was discontinued. She was started on medications for blood pressure. She was 90 pounds, and they kept increasing the blood pressure meds, which resulted in falls and subsequent hospitalizations. So that's my personal perspective. From my professional perspective, having been a pharmacist for many, many decades, I've witnessed the fact that in the real-life setting, these medication lists, which form the basis of orders, are created by a number of individuals in different practice settings. So in a doctor's office, you might have a medical assistant who's maybe had 5 hours of training in order entry take a medication list that then becomes the basis of future orders. Again, through my career in pharmacy, I've witnessed the explosion of complex new medications to treat a variety of diseases. We really have a huge armamentarium of medications available. We have an elderly population. Many times patients are being seen by multiple physicians. And so this ambiguity in terms of making sure the medication list is accurate is particularly an issue when patients are the most vulnerable, when they're admitted to our hospitals. And so when we look at our high-risk patients, we try to figure out how we as part of the healthcare team can ensure the accuracy of the medication list so that the orders that are written subsequently are based on the intent of what the physician desired. So in our organization, we look at this team-based approach as a three-legged stool. So the pharmacist is the middle of the stool. The physician is the one who's determining the needs of that patient. The acute needs to stabilize that patient when they're being admitted and create a plan of care that is to be carried out by the other healthcare professionals. The pharmacist interprets that order in the context of the patient. We're not replacing the physician work or the nurse's work. We're there as part of this three-legged stool. If you think about it, we all completed training in English and know that and how to construct a sentence, how to conjugate a verb. A medication order is a sentence. If the drug, the dose, the route, the frequency, or the duration are incorrect, we're going to see harm.
Thank you very much.
Okay, thank you.
Any additional witnesses wishing to speak in support, please feel free to come to the mic and name affiliation if you wish to do so.
Thank you so much for having me. My name is Mitu Mullen. and I serve as the section chief for hospital medicine at UC Davis Medical Center. I also serve as the site principal investigator for a large collaborative trial called the Marquis Study, Medication Reconciliation Quality Improvement Study. And this is a large trial, including over 18 sites, looking at best practices in medication reconciliation. And I'll just cut to our conclusions. Basically, what we found is that pharmacy technicians taking accurate pre-admission medication lists, we were able to cut down medication discrepancies or medication errors by over 65%. On average, patients that showed up at our institution had about 5 discrepancies or medication errors per patient on admission. We were able to cut that down to less than 1. So the results were quite dramatic, and we've found that these medication discrepancies or medication errors lead to less adverse events, increased savings in terms of cost utilization. So we feel strongly that pharmacy technicians helping to supplement physicians really do our patients a lot of benefit.
Great, thank you very much. Any additional witnesses wishing to speak in support? Name and affiliation if you wish to do so.
California Society of Health System Pharmacists. We want to thank the Senator for his recent amendments. We're in support.
Good morning, David Gonzalez on behalf of the California Life Science Association, also in support. I want to thank the Senator for introducing this.
Good morning, Lorianne DiMartini, CEO for the California Society of Health System Pharmacists. On behalf of the board, we're in support of this bill.
Thank you very much. Any additional witnesses wishing to speak in support? Seeing none, any witnesses wishing to speak in opposition? Please feel free to come up to Mike.
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. We do have an opposed position. We just wanted to clarify that if a pharmacist or a pharmacy technician isn't available, that another licensed professional could also do the medication profile. We've been working with the Senator. He's open to our amendment. At this point, we'll work it out moving forward. Thank you.
Thank you very much. Any additional witnesses wishing to speak in opposition? Seeing no witnesses in opposition, there's been a motion and a second. Any questions or comments from committee members at this time? Assemblymember Blue.
Thank you, Mr. Chair. It's rather shocking that this type of protocol doesn't exist already. For many of us, and I met with Dr. Shane this morning, we have friends or relatives who, for whom this has been an issue in the past, and we are more and more. I'm not saying this as a negative necessarily, but we're more and more dependent on pharmacological interventions in our health care. So this would only be a growing problem, and the idea that we make certain that the medications that a person is on at the time of treatment in the emergency room or anywhere else in the healthcare system for that matter is just of critical importance. So I'm very happy to support this measure.
Thank you,
It's
Assembly.
a big step forward.
Thank you very much. Any additional witnesses or additional questions or comments from committee members at this time? Senator Stone, do you wish to close?
Thank you, Mr. Chairman, honorable members. I appreciate your consideration of this bill. There is a triad in care, and that is the patient, the physician, and the pharmacist. And working together in collaboration, we believe that we can reduce the morbidity and mortality associated with drug errors, and I strongly urge an aye vote.
Thank you very much, Senator Stone. Very much appreciate your expertise and passion on this issue, and thank you very much for the witnesses who have also come to testify in support. There's been a motion and second, and this does enjoy an aye recommendation. Committee Secretary, please call the roll.
Motion is due pass as amended to the Committee on Health. Lowe?
Aye.
Lowe, aye. Bro? Bro, aye. Arambula? Baker? Baker, aye. Bloom? Bloom, aye. Chen? Chen, aye. Chu? Cunningham? Eggman? Eggman, aye. Fong? Fong, aye. Gibson? Gibson, aye. Grayson? Grayson, aye. Holden? Irwin? Irwin, aye. McCarty? McCarty, aye. Medina? Mullen? Obernolte? Obernolte, aye. Ting.
That has 12 aye votes. We'll leave the roll open for absent members.
Thank you, Mr. Chair. Thank you, honorable
Thank you
members.
very much.